Thank you. I hope you enjoyed that video. It's a pretty good overview, I think, of the Nexstar system. Now, for tonight's program, I interviewed our two faculty members, and before diving in on Nexstar, I asked them to describe how they evaluate new products or technologies. Now, surprisingly, they both are fairly conservative, rather skeptical of new technology, and particularly given their busy schedules, would not entertain a new technology unless there were clear cost, patient outcomes, or surgery improving capabilities. So both Dr. Sukin and Dr. Cox, incidentally, will be available for Q&A near the end of this masterclass. Okay, so to begin, I asked both doctors to explain how they view new technology generally, to define augmented reality, and then in as practical a way as they can, and they've used this system in a number of surgeries, how they are using it in their practice currently. Thank you. How do you go about adopting new technologies?
I like to analyze it. I like to really critique it. I'm somewhat skeptical. With all that being said, I have been doing computer navigation for more than 15 years. And I've looked at robotics over and over through those 15 years as it's evolved and been very skeptical and have not adopted. So I think I'm kind of in the in-between camp. I want to see the value equation answered. I want to make sure that if we're adding technology, we're adding time to our surgery and costs, that we actually improve our outcomes and workflow in the operating room and for the patients.
So I don't adopt all new technologies. I don't think, at least I don't want to be the person who just says everything new is great.
I think, when you look back at computer navigation, you look at robotics, both of them have shown themselves to be highly accurate in achieving specific angles and removing outliers from the equation. We don't see as many patients that we look at the x-ray and go, wow, how did I do that? So it really takes the outliers away. But what both of them have truly failed to do is improve outcomes for patients.
Words that I live by, one of my mentors and fellowship director in San Francisco, Gene Wolfe, told me, he said, if you're fixing rotator cuff the same way 5 years from now as I taught you this year, then we've taught you nothing. He kind of said it in jest in the middle of a case one day, but there's really nothing truer than that. I mean, I think you can do a very good job in doing things the way you've always done them. But I don't know that means you're doing the best job for the patient relative to what else is out there.
As you do that initial sort of evaluation, and even as you talk to your colleagues about something that's perhaps interesting and new, at least on the surface, what kind of value propositions do you consider and do you look for?
We're also busy on both sides of this equation. Everybody's so busy that it's hard to find time to meet with the doctor, and it's hard for the doctor to find time to meet with the rep in your example. But I think we owe that to ourselves. And I think you can't say yes to everything, but you can't be the person that says no always either. I think, again, if you want to stay on the train, or if you want to get off the train when you think you've found some success, I think, well, there's an old science fiction quote that says, the future is already here. It's just not evenly distributed. And I think
that's good.
There's so much truth in that, that if you fail to look at new opportunities, then I think you really fail to grow.
If you look back 20 years, 75-80% of patients had good and excellent outcomes, and today 75 to 80% have good to excellent outcomes. And so we have to, first of all, analyze why is that occurring, and then secondly, how do we make that go away? And I do think that that has to be the focus, especially in this world of the value equation. We can't introduce technology that has any outcome other than improving outcomes at a lower cost.
So as you look at that, if you look sort of the different things, what are problems in your experience, particularly shoulder surgery, where some of these new basket of technologies might have some effect?
If you think about sort of the new frontiers, which have started to exist a little bit, you're talking about robots and augmented reality and all these different things that we're doing now. there has to be, there, I think that what we're really doing is eliminating things outside the curve. So if all I do is shoulder surgery, I think most of the time a well-trained surgeon is going to do a good job. And if everything goes well, the patient does what they're supposed to, and biology does what it's supposed to, then they're going to have a good outcome. The question really, and the challenge is, how much less than optimal outcomes, how much of that do we accept as just the way it is? And how much of that can we really influence? Because I don't care how many you do, if you do 100 shoulder replacements, there's going to be one or two of them where the x-ray doesn't look exactly like you thought it would look. And maybe their range of motion isn't as good as it's supposed to be in our head. And it's archaic to think, oh, here's about how much range of motion you could expect. Well, we're basing that on what we've seen out of patients' previous outcomes.
Right.
Does that mean that we've reached the pinnacle? Like, this is the optimal and there's no better way? And I don't think it is. And I think that if you can eliminate the outliers, and here in shoulder surgery, if you can eliminate, we put these base plates on the scapula for reverse shoulders. If we knew that 4 degrees, I'm making this up, okay, because there's debate here, but if we knew that, say, 4 degrees provided of inclination allowed the patient a little bit more range of motion, well, who in their right mind would say no to ensuring you're at that mark?
That's
right? There has to be a value add to consider in any capacity, for me at least, changing something that I know is working. The challenge for all of us, and I'm no different, so this is not me lobbing in from the stands, all of us, I think, professionals in any capacity, physicians, lawyers, mechanics, whatever, when you find a successful way of doing a particular thing, it is difficult to see without bias, new opportunities. I think that's healthy in some ways. I mean, you can't just look at everything without any bias. You have to see it through that bias. But you've got to find a way to look at the new technology and say, am I doing the best I could do, or could this make me better?
What is surgical augmented reality in a practical sense?
Well, I think that the best way to think about augmented reality is actually not think about it from a surgeon's perspective, but think about it from a pilot, pilot in a flight simulator. I mean, that's augmented reality at its finest, where it really feels like they are flying a jet. They are being put in critical situations and asked to, avoid a crash, etc. Same thing. Our military uses augmented reality to train, and it's really putting data, science, visual cues such as a CT scan data in the surgeon's world, X-ray data in front of the patient. In augmented reality and knee replacements, what we're really looking for are biomechanical indicators and trying to see what are the biomechanics of that patient. And then as we do the operation, how do we get to that same exact biomechanic endpoint?
I think it means different things to different people. So if we zoom out just a little bit, I think every platform that's sort of available now, becoming available, has a slightly different take. Much of it, I think, has to do with what's offered by that particular platform as far as what the take is. What I've told, the way I've described it to my patients is, in a normal preoperative plan, I'm looking at their CT scan, maybe drawing measurements, and in my head, I have a game plan for about where I want everything, where I expect to have bony ridges, these things. And we have a plan to sort of get it where we want it to be. And then if you could take, and in shoulder replacement augmented reality, at least the system that I've had my experience with, it gives us the ability, almost like picture Top Gun, where you have these radars, like one is my hand in real time and one is the target, to get these things to where they align and sort of, it doesn't lock in like an F-16, but you at least see exactly what you're doing. And what I tell my patients after surgery, their families, because a lot of times their family with COVID, as weird as it sounds, hasn't been in some of those conversations in the clinic.
Mhm.
And so more than you would ever think now, where there's a lot of times where I'm meeting some extended family in the, after the surgery, when I'm telling them how everything
Sure,
went, so forth.
sure.
And the way I've described it is, what if you were trying to hang a heavy mirror in a wall? What if while you were looking at the wall, at the exact same time, you could see that wall from the other side of the wall? What if you could see the studs instead of feeling for them,
Now that's
right?
awesome. Yeah.
And so you could just walk up and at the same time see the wall from this view and this view, have something, and in the system that we use, I see that in the periphery of my glasses where the wall's still right in front of me. I'm not in some fantasy land like we're, pretending like we're on a roller coaster or something. It's a real surgery through clear lenses right in front of me. But along the periphery, we have the ability to, as I'm holding the drill, look at that stud from all these different angles. You just don't miss the stud.
So is the system you're using Nexstar?
Yes,
And
it
if
is.
it is, why that particular system?
At least it's preventing a potential clinical problem by not letting me be erroneous in my effort. You could choose to override it. The surgeon's still in charge, but it's at least a fair and honest opinion of what you're doing. It's not subjective, right? These are objective data that I'm getting in real time as far as angles that we've planned. And it's to saying, I did this in a case last week where in my plan with the CT scan, I anticipated a particular angle. And as I drilled that angle, I thought, that doesn't look exactly right to me. And I modified that angle a little. But I even told the representative for the company who was in the room that day, I said, had I not had this,
Right.
I would have been more off. I corrected this based on this projection, but I sort of met in the middle with it, with the ability to see it in real time. So I like the technology NextAR because it gives me the ability to see in real time and adjust in real time what I had planned preoperatively and get feedback with every step. If I don't like something, I can go back a step and recalibrate and do things. You're never locked into a plan. So it's not a system that makes you execute a predetermined plan. It's a system that lets you sort of gives you feedback on how well you're doing relative to your plan.
The patients ask about robotics a lot. I don't think patients at this point um, understand the difference between robotics and augmented reality. But I think the big anchors are that we want to get the patient back to a point where they have a high level of function. It's all about quality of life. The reason patients come see us has nothing to do with the fact that their knee hurts. It's that they've given up a bunch of quality of life and they're not living the way they want to live anymore. And where I practice in Montana, we have very active, farmers and ranchers and skiers and, athletes that are pushing their knees very hard after they're replaced. And if they have mid-flexion instability, which is one of the biggest problems with total knee replacement, they can't perform at that level. So I think we have dramatically decreased mid-flexion instability with NextAR and Sphere, the Sphere medial pivot knee. And I think we've also, we're seeing the patients recover much quicker, get their range of motion much quicker. And I think if you take the medial constraint or medial pivot knee, the Sphere knee that Medacta makes, which basically constrains the medial femur, medial compartment, and has a non-constraint lateral compartment. When you combine that with NextAR, you can get dramatically closer to the normal kinematics, the normal biomechanics of a knee that has not had arthritis, has not had an arthroplasty of any sort.
To the extent that you know other systems, where does NextAR kind of fit in that market? Does it fill a gap that's being left by some of the other systems.
So when you look at the technology, it doesn't occupy much space in the operating room. The registration can be very rapid, very quick. It's very few data points on the femur, very few data points on the tibia. And I think the learning curve is somewhere between 5 and 10 cases, which is different than a lot of technologies that we use. As far as what it's giving the surgeon, it is giving the patient exact kinematic curves, medial collateral ligament, kinematics, lateral collateral ligament, kinematics, stability of the knee, all that is coming up before the surgery really ever starts. And then once the trial implant goes into place, the comparison can be made by the surgeon.
There's a few platforms that have sort of arrived at about the same time. They all have their own sort of nuances, and we're all going to be more comfortable with the things that we've had exposure and experience with. And so that there's an inherent bias there for me because I've had more exposure to the Nexstar system. So, but there's varying elements of which portions of the plan you could modify or change and then still move forward with the rest of the plan that you had for that case, meaning that if I change a particular angle or choose to do something a little bit differently, I can still get feedback off the rest of what I'm doing. So you don't have to abort the system or whatever. I like its ability to show me within the software some predictions as far as range of motion and some other things.
Yeah, that's great.
And I think that's really where I see I see good things in Nexstar in the future as much as I see them in the present. I think that I think we'll continue to get better and better. I mean, predicting exactly how much range of motion somebody can have, that's hard. That relies on what their muscles can do and so forth. But I think if you can define exactly what the abilities of that setup is, you know, that if you do this at this angle and this of this size and all the different variables that we have of what we expect the range of motion that's available to be, I see a future where we're not only just putting in implants better, but we're better able to predict exactly how much range of motion, which then parlays into all this other stuff. There's a big difference in range of motion between living pain-free and playing tennis pain-free, or ability to play tennis at all. I think through this technology, only as the technology is used more and more will we start to really see where all it can lead. I think it's pretty wide open.
These kinds of technologies, do they not have to justify themselves economically?
The biggest economic advantages are that there's very few disposables in the operating room. We're basically doing a preoperative CT scan, and we've been able to negotiate, I think, very good price point for that with our imaging center that we're using, and very few disposables, and essentially a fairly low economic footprint. The size of the equipment is small, and I also think the amount of debris that's going to the landfill is relatively small in comparison to other technologies that we've used. So, you know, we're hitting a lot of the things that people really care about.
And I think that challenge is only getting greater because, you know, it was easy for decades or longer for surgeons to say, hey, I really want this. And the hospitals say, well, it's more expensive, and say, well, it's worth it. My patients are doing better. Well, what if you flip it like some bundled payment agreements and so forth and said, hey, here's the dollars that you are going to receive for this surgery. Spend it however you wish. If the surgeon still says and the hospital system still says this is still worth the spend, then you know you have something good. You know, I tell all my patients that nothing's more expensive than failed surgery.
Medacta's moved very quickly and given the surgeon an incredible bailout where they can move away from the custom cutting blocks to a metallic cutting block and even register the bone itself and not the instruments. And that's something relatively new. I'm very impressed with how quick they've moved.
Yeah.
And that again allows the surgeon to move quickly in the operating room if they're not happy with data, and not just eliminate the technology. The coolest thing about it is the potential. We literally are seeing things on the computer. We have no idea what they mean yet because we've never seen them as surgeons. That's number one. Number two, we can start linking clinical data to decision making. This is the part of the artificial intelligence where a surgeon can, for example, I recently was involved in a sawbones with a surgeon that had only seen this. And when the trials went in, his medial collateral ligament was perfect. His lateral collateral ligament was not. There were 3 options to fix that and make the biomechanical curves look perfect. I see the day where the computer starts to make those suggestions, and then based on database, lets the surgeon know what each decision, what the variance is in those decisions. So
I
I
think
think the potential is huge.
If you can start to eliminate these multi revisions and all these redo surgeries and not only that, but the downstream costs too of returning people back to a line of employment that they were doing before, and eliminating some lost wage contribution to the overall cost scenario, this term sort of cost of care starts to get very muddy, because is it worth, and making up a number, is it worth spending an extra $1,500, let's say, to reduce the risk of failure by a certain percent? Well, it probably matters what that percent is, and how many people do need to receive Nexstar or any system to then eliminate the risk of a revision. That's where it truly plays out. But I think as most technologies are, unlike the pharmaceutical world where the cost of a drug is relative to how many drugs failed before it, right? I mean, you're paying for the 90% of drugs that never make it to market.
That's for sure.
Right. And that's the beauty of software driven algorithms and software driven progress, is that these are not like tons of money spent on new metals and new things that either work or don't.
No, that's
These
right.
are algorithms and programs that can be changed
Updated.
economically.
Exactly.
Right? And updated.
Exactly.
Yes.
I guess one interesting question is, would there be a time when you would not want to use Nexstar?
Right now, it's relatively new, and we are not using it in everybody. I think we're trying to figure out exactly where it belongs, and you do need some lead time to get the CT scan and have the engineers look at the CT scan, produce the custom cutting blocks and arrays. So if you have somebody you're going to put on the schedule very quickly, that might not yet be possible. But I do think that a higher and higher percentage of patients will have this technology utilized on them in the future.
The instinct would be to use them on your most difficult cases, so that things where your eye doesn't get fooled. I mean, the analogy that I use for folks is there is an art form to creating green complexes as a golf course designer. Okay, there's an art form to creating the illusion of a break left, break right, uphill, downhill. Think about all the professional golfers who have been at Augusta National 30 times, right? And they putt, and they're just like, how does that? It's because of what your mind sees in that peripheral landscape and how you envision the behind the green. The body does that to us. These humps around and these undulations and these things, I truly see that as a very analogous scenario. We can easily be fooled by the things around what we're looking at as much as the very things that we're looking at. So the instinct is to say, use them on the most difficult cases. Having said that, there's a lot of people that miss 2-foot putts because it looked like it went left and it really went right.
And I think the other thing is, I've asked some of the engineers at Medacta, do you think someday we could actually show the kinematics? In other words, a gait lab analysis of what this knee that we're operating on looks like in the future. The excitement here is that I think we're going to very rapidly be able to see data on whether or not we're making a difference in that 20% of patients that are not happy with their knee replacements. I think we're going to be able to make very small modifications in the algorithm with Nexstar and then see what that means clinically. And maybe for the first time in a couple decades, have 95, 98% good and excellent outcomes instead of 80%.
Thank you, Dr. Sukin and Dr. Cox. We'll be meeting them again during the question and answer period later. A couple years ago, I had the opportunity to attend one of Medacta's training program. It was a cadaver lab, anterior hip surgery. I've been in orthopedics for more than 30 years, and Medacta puts together excellent training programs. Other doctors have offered the opinion that Medacta is an education and training company that happens to make implants. There's a lot of truth to that. So before we start the Q&A, I asked Medacta if they could provide a short video about their educational programs, which are organized through their M.O.R.E. Institute. And so we're going to play that short video. This also, by the way, will give you, the audience, the opportunity to prepare your questions for our faculty and then send them in via the Q&A button that should appear at the bottom of your screen. Okay, thank you. And now the M.O.R.E. Institute video.
So what does Medacta mean to me? Medacta to me is simply an education company that happens to sell implants. Medacta's primary goal to me is helping surgeons achieve the results for their patients that they want.
How is Medacta different from other orthopedic companies? Although all orthopedic companies survive through sales, Medacta has understood that they survive through sales by education.
One word to describe Medacta, I would have to say innovative.
I think that the surgeon's really never alone out there. We're always there to help them with their surgical technique, to give them a better result, to make their patients do better, which makes everybody successful.
At Medacta, we believe that innovation requires education, and no surgeons should be alone when learning new technologies. Education is one of the key pillars of Medacta. The M.O.R.E. Institute has been created to organize worldwide structured programs to help surgeons going through the learning curve associated with any change.
Well, Medacta really devotes a lot of time and resources to educating surgeons so they can perform more efficient and better surgeries and deliver better patient outcomes.
Please, let us know if there is anything we can do to make your Medacta experience exceptional. Thank you.